The optimal sequencing of anti-BCMA therapies in multiple myeloma is a very, very hot topic. I would even say it's a $1 billion question because we don't know yet what is the optimal sequence. And actually, there are some speculations about this. On one hand, patient, but also physicians and caregivers would prefer to give CAR T cells first because it's a single shot treatment and patient will enjoy some treatment-free interval. And this is important for the quality of life of the patient. However, as you may guess, CAR T cells are not easily available everywhere. They are relatively expensive, but also there are not, I would say, enough availability and widespread or ease of use of these CAR T cells. You need to be in highly specialized centers. On the other hand, you have the bispecific antibodies, T cell engagers against BCMA. We have teclistamab, which is already approved. We have some very strong and convincing data with elranatamab. There are many others being developed. These are easy to use, immediately available, off the shelf, but they would require a chronic treatment, so several infusions and likely until progression. So you can see the target is the same. On one hand, it's a single shot treatment. On the other hand, it is more a chronic, regular treatment. So how can we choose? What we know from the available literature, with all the limitations related to sub-analysis, small groups, etc., that patients who received CAR T cells against BCMA and progressed after CAR T cells are able to receive the bispecific antibodies and will respond. Maybe the response is slightly lower, but definitely they can respond and enjoy additional disease-free survival. On the other hand, if patients have received bispecific antibodies, it looks like that the response to CAR T cells later is not going to be optimal. Is this related to the fact that we have exhausted the T cell that will be used to generate the CAR T cells, or for any other scientific or medical reason? The story may be also a little bit more complicated if we are alternating between tumor antigens, because you know that we have bispecific antibodies against GPRC5D, like talquetamab. We have also CAR T cells against GPRC5D, not approved, but hopefully in the near future. So you can see the question is a little bit complicated. It's not only about the same antigen, it's about also the different antigens. It's also about the practicality. I think today's decision-making process is mainly dictated by the practicalities. Also, maybe from scientific point of view, one would prefer CAR T cells followed by bispecific, not the other way around.